This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Fluids and Barriers of the CNS, titled Cognitive Assessment Methods and Outcomes Following Shunt Surgery in Idiopathic Normal Pressure Hydrocephalus, or iNPH, a systematic review and meta-analysis.
This is a topic that hits home for anyone in the clinic. We often see these patients with the classic triad: gait disturbance, urinary incontinence, and cognitive decline. But the dementia part of that triad is often the most heterogeneous and difficult to quantify.
Exactly, Dr. Eris. This study really dives into the specific patterns of cognitive impairment. They looked at a cohort where patients were divided into two very distinct subgroups based on their baseline mini-mental state examination, or MMSE scores. Group 1 consisted of patients who scored less than 24, essentially the demented group, while Group 2 scored 24 or above, classified as non-demented.
That's a crucial distinction. In the surgical world, we often wonder if the demented patients are too far gone to benefit from a shunt, or if their cognitive issues are even related to the hydrocephalus at all, versus a comorbidity like Alzheimer's disease. What did the paper find regarding their pre-shunt status?
It was quite revealing. Group 1, the demented group, performed poorly on both the MMSE and the Kendrick Object Learning Test, or KOLT, prior to surgery. But Group 2, despite being non-demented by those standard scales, wasn't actually normal. When they were put through more rigorous testing, specifically the CANTAB battery and verbal fluency tests, they showed a specific pattern of impairment.
And that's where the frontostriatal piece comes in, right?
Precisely. The authors note that Group 2 showed a specific pattern of impairment on tests sensitive to frontostriatal dysfunction. This is a key finding because it suggests that even when a patient doesn't meet the formal criteria for dementia, they are still suffering from measurable executive and attentional deficits related to the hydrocephalus.
And that's where the post-operative outcomes comes in, right? Because that's what our residents and colleagues really want to know. Does the shunt actually fix the dementia?
The results for Group 1 were actually quite striking. Pre-shunt, these 5 patients were in the dementing range, but at the 6-month post-shunt assessment, they showed a significant post-operative recovery. In fact, all patients in Group 1 moved into the normal, non-demented range on the MMSE and KOLT.
That is a powerful clinical message. It suggests that the cognitive impairment in iNPH, even when it looks like significant dementia, can be highly reversible. It's not just a slowing of decline, it's a recovery of function.
It really is. However, the story for Group 2, the non-demented group, was a bit more complex. While they didn't show signs of dementia on the MMSE or KOLT either before or after the shunt, that frontostriatal dysfunction I mentioned earlier actually remained post-operatively.
That's an important nuance. Why do you think that pattern persisted?
The paper suggests that this pattern is distinct from what we see in Alzheimer's disease. In mild Alzheimer's, we usually see a different profile of memory and attentional deficits. The persistence in iNPH patients might point to the structural and functional profile of impairment being more deeply rooted in those frontostriatal circuits, which might not always bounce back as quickly or as completely as the global cognitive scores suggest.
The study also looked at MRI findings, didn't it? As neurosurgeons, we're always trying to correlate the imaging with the clinical picture.
Yes, they had post-shunt MRI data for 9 of the 11 patients. They found that 8 of those 9 patterns of structural damage corresponded well to the cognitive performance they observed. This reinforces the idea that we aren't just looking at symptoms, but at a structural and functional profile of impairment.
This brings up the issue of heterogeneity. We talk about iNPH as one disease, but this paper really highlights how different these patients can be.
Absolutely. The authors emphasize that these findings are useful for 3 main reasons. First, they detail that specific structural and functional profile. Second, they demonstrate the heterogeneity in the iNPH population and show how the severity of initial cognitive impairment can actually affect the outcome post-shunt.
And the third reason?
The third is that these detailed assessments may provide a means of monitoring the cognitive outcome of new procedures in shunt surgery. Instead of just asking, are they better, we can look at specific domains like verbal fluency, memory, and attentional tasks.
I want to circle back to the Alzheimer's comparison. In a busy clinic, it's often a coin toss for some residents. Is it NPH or is it AD? The paper mentions that the iNPH pattern is distinct. Can you elaborate on that based on their data?
The paper points out that the frontostriatal dysfunction seen in the iNPH patients is a specific signature. In mild Alzheimer's disease, the impairment often starts with different mnemonic and attentional patterns. The iNPH patients, particularly those in Group 2, show deficits in planning and working memory that are characteristic of those frontostriatal pathways. This distinction is vital for accurate diagnosis and for setting expectations with families.
It's also interesting that they used the CAN-TAB battery. For the residents listening, the CAN-TAB is a computerized battery that is very sensitive. It's not your standard "what day of the week is it" MMSE question. It challenges executive function. The fact that the non-demented group failed these while passing the MMSE tells us we might be underestimating the cognitive burden in our mild patients.
That's a great point. If we only use the MMSE, we might miss the subtle but life-altering executive dysfunction that these patients are dealing with. And if we don't measure it, we can't track if the shunt is helping those specific areas.
So if you're a resident looking at a patient with a normal MMSE of 26, but they have the gait issues and the ventriculomegaly, this paper suggests we should be looking deeper.
Exactly. Their non-demented status doesn't mean their cognition is intact. It just means the standard tests aren't sensitive enough to catch the frontostriatal issues they are facing.
Looking at the group that did have dementia, Group 1, the recovery was significant. Did the paper suggest why they recovered so well?
They focused on the fact that all Group 1 patients moved back into the normal range. This suggests that the dementia in these specific iNPH cases was likely a direct result of the pressure or flow dynamics that the shunt corrected, rather than an irreversible neurodegenerative process.
It really underscores the importance of the pilot study aspect here. Even with a small N number, the divergence between the two groups is statistically and clinically relevant. It tells us that iNPH is a spectrum. On one end, you have reversible global cognitive decline, and on the other, you have persistent specific executive deficits.
And it's those persistent deficits that might explain why some patients' families say his walking is better, but he's still not quite mentally after the surgery.
Right. We often call those partial responders, but according to this data, they might just be responding in a way that is consistent with their specific preoperative profile.
The authors also mention that this study can help inform the monitoring of new surgical procedures. If we develop new valve technologies or different shunting protocols, we shouldn't just be looking at the MMSE. We should be using these more sensitive frontostriatal-focused tests.
Let's summarize the key takeaways for our listeners. If you're in the clinic or preparing for boards, what are the high-yield points from this Iden et al. Study?
First, iNPH patients are heterogeneous. Don't treat an MMSE of 18 the same as an MMSE of 28. Second, patients with significant cognitive impairment, the demented range, can show remarkable recovery post-shunt, often returning to normal ranges.
And third, the non-demented NPH patients often have a specific pattern of frontostriatal dysfunction that might not be captured by basic bedside tests and may persist even after the shunt is placed.
Finally, the cognitive profile of iNPH is distinct from Alzheimer's disease, which is a critical diagnostic distinction.
This study really highlights the need for a more sophisticated approach to cognitive assessment in neurosurgery. We can't just be plumbers fixing the flow. We have to be neurologically minded clinicians who understand the specific circuits we're trying to save.
Well said, Dr. Aris. It's about the quality of life and the specific functions that allow these patients to interact with their world: planning, attention, and executive control.
That's all the time we have for today. Thank you, Dr. Alara, for breaking down this study for us. It's certainly going to change how I talk to my patients in the morning.
My pleasure. Thanks for having me.
To our listeners, thank you for joining us on the Neurosurgery Hub podcast. Stay curious, and we'll see you in the next episode.
Goodbye, everyone.